As we will be hearing from four experts currently working on self-care, specifically the use of self-injection contraceptives are popularly known among the FPRH community as DMPA-SC injection. And our panelists will be sharing their thoughts and experiences as we explore today what self-care means within the Asia region, how people are engaging in self-care, why self-injectable contraceptive uptake remains limited in the Asia region, and lessons learned from experiences implementing self-injection in Africa that could be translated in the Asia region. So we will hear from Saumya Ramarao, the co-lead of the Evidence and Learning Working Group of the Self-Care Trailblazers Group, on what really self-care is within the context of FPRH and how it is being understood. Please wave your hand to the audience, Saumya. Can you see Saumya? There, thank you. We also have with us Jhpiego Pakistan Senior Research Manager Kanwal Kayum, who will share with us the key insights they have discovered upon completing their formative research on people's readiness for self-injection as a contraceptive option in Pakistan. Hello there, Kanwal. Can you wave on the screen so that everybody will see you there? Thank
Hello,
you.
everyone.
And meanwhile, Assistant Professor Govinda Prasad Dungana of Far Western University Nepal will discuss the lessons they have learned as they introduce DMPA-SC injection in rural and remote villages of two districts in Far Western Province, Nepal. Welcome, Professor Govinda. There. And lastly, we also have with us the Regional Director of the DMPA-SC project in West Africa, Celesta Compaure, who will share their lessons learned in implementing self-injection in Africa that could be helpful for the Asia region. And we will be having the question and answer portion at the end of the panel discussion. However, you are free to type in your questions in the chat box anytime because someone from our team will be collating all the questions coming in throughout the chat box, and we will ask that to our panelists during the Q&A session. All right, next slide, please. So to start, it would be best if all of us here right now would have a common and basic understanding of what self-care is. And we are fortunate that we have with us here Saumya Ramarao from the Self-Care Trailblazer Group. So Saumya, can you please enlighten us with a quick yet complete overview of what self-care is within the context of FPRH? And also, what would you like people to understand about self-care? Saumya?
Thank you, Gaio. Hello, everybody. Good day, wherever you are in the world. Let me begin by first thanking Knowledge Success for inviting the Evidence and Learning Working Group of the Self-Care Trailblazers Group. For those of you who may not have heard of the SCTG or the Self-Care Trailblazers Group, this is a global coalition of over 300 members, with members coming from over 99 countries, 2/3 of whom are in the global south. And the vision of the coalition is to advance the safe and effective use of self-care. So having made that pitch about what the SCTG and the Evidence and Learning Working Group is, let me begin by talking about what self-care is. Can we go to the next slide, please? So here on this slide, you will see the definition that the WHO has put out. It's a very simple definition, but each word in this definition is important. It is the ability of individuals, families, and communities to promote and maintain health, prevent disease, and cope with illness with or without the support of a healthcare provider. So I want to highlight the two aspects here, with or without the support of a healthcare provider. So self care in the FP and reproductive health space is really about empowering health consumers to maintain their own health in the ways that they find convenient for them. Let's stop there, Grace, and hand it back to you.
All right. So that's the basic, right? Overview, basic definition of what self-care is, like empowering really the consumers in terms of their healthcare. But I'm sure there are many variations, right, of different groups or communities on how do they define self-care. So based on your experience, Saumya, what does self-care mean to different populations like youth or people living with disabilities, people in crisis settings?
Sure. Thank you, Grace Gaio. So, self care, like I said, it's about helping individuals manage their own health. So, oftentimes, this means in the family planning and reproductive health space that they can use products and technologies which they can use themselves. So, it could be self injection for contraceptives. The examples that you will hear from the other panelists, the DMPA-SC, or it could be doing pregnancy testing at home on your own to know whether you're pregnant or not. And it could also be taking um, self testing or self collection of samples for, say, for cervical cancer. So that's a range of products that health consumers can use. And it gives them the option of picking up these products from a variety of outlets, meaning they don't need necessarily to go to a healthcare provider sitting in a particular health facility, but can pick up the products from, say, community based pharmacies or from online pharmacies, from community based health workers, and from a variety of points of care of this kind. In other words, self care gives people options about not only which provider to go to and which service point to go to. So, having said this, let me give you an example of how it might apply to a particular population subgroup, let's say youth. We know that youth in our family planning world are often not necessarily welcomed, or they might themselves feel stigmatized seeking certain types of care at certain health facilities. In such cases, youth might find it more comfortable and convenient to seek care from outlets such as pharmacies. For example, that's where they might go to pick up pregnancy tests or to pick up emergency contraception. So there are these different ways that we can provide services to youth. Youth too might like to learn about their own reproductive health options and what are the various uh, tools that they can use, how to educate themselves through digital means. So these are some of the examples about how self-care can be applied for people living with for young people. So similarly, let's think about, I believe you asked about individuals in crisis settings, Gaio.
Yes,
So,
yes, yes.
correct. So now what happens to, let's think about girls and women who have just passed through a crisis. It could be either a political displacement marked with violence, or it could be a natural disaster. And so here they are in a humanitarian setting. And you can imagine the relief these girls and women have if they can self test for pregnancy in case they've had a sexual assault, or if they can take emergency contraception, or they can take some medicines on their own to uh, to make sure that they are but they're not pregnant. Or it could also be if they can self-test for HIV, so to make sure that they have not acquired HIV. So these are some examples of how some communities and some settings might find self-care approaches to be useful to them. At the end of the day, the underlying principle of self-care is meeting health consumers on their own health journeys. So, in other words, it's very people centered. It's all about people. I'll stop there, Gaio.
Thank you, Saumya. It's all about people meeting consumers in terms of their health needs. Thank you. Thank you, Saumya, for that overview. At least now all of us have, a common understanding of what self-care is. Now, let us zoom in to Asia. So the recent experience for those who are most countries in Asia being hard hit by COVID-19 and experiencing massive lockdowns that severely limited people's access to family planning and SRH services and commodities have magnified the need for self-care. So we could say it is a humanitarian or crisis setting. So as a response to ensure the access and options for FPSRH services in such scenarios, one contraceptive option being promoted is self-injection, which provides autonomy, freedom, privacy, and convenience. And this self-injection is also called DMPA-SC. So this DMPA-SC is being newly introduced in the Punjab province of Pakistan. And this is to complement the government's vision to accelerate its progress towards achieving its FP 2030 goals, which is to improve the contraceptive prevalence rate, offer equal access to quality FP services, and expand method choice for all women. So just to give context, Jhpiego Pakistan, with financial support from the Bill and Melinda Gates Foundation, conducted this formative research to explore the needs and interest of women for DMPA-SC self-injection and to determine, of course, how to offer, introduce, and support the use of DMPA-SC self-injection in ways that best meet women's needs. So, from understanding an overview of what self care is, let us hear now from one of the countries in Asia, Pakistan, on the acceptability and feasibility of self-injection. So we have with us here Jhpiego Pakistan Senior Research Manager Kanwal Kayum. So Kanwal, my first question is, so now that Jhpiego Pakistan completed a formative study again on the acceptability and feasibility of this DMPA-SC in Punjab, what key insights did you discover in the study about people's readiness for self-injection as a contraceptive option? Kanwal?
Thank you, Gail. We have got very interesting insight about awareness, decision making, initiation of self injection, and continuation of DMPA-CS self injection. For instance, we have got to know from this formative research that women are eager to learn self-injection technique. Men think that women will be afraid of needle, while women shared no such concern. Husband support is incredibly important to encourage women for self-injection. In order to seek FP information, women trust community health worker the most. Mother-in-law is also a source of information for FP services, but she is not the decision maker. When it comes to who makes the decision, we have found that couple makes FP decision together. Whereas women are more knowledgeable for FP method and its side effect, mother-in-law is influential if daughter-in-law is not educated. It was also commonly mentioned that educated women may choose self-injection more and will be easier to train on self-injection. When we asked a healthcare provider and community worker how self-injection can be initiated, so they have identified that giving a training to those women on self-injection technique is a must. They want to observe at least 2 to 3 self-injection practices by the client before handing over multiple doses to her. Also, practicing on a model would improve her self-confidence. Also, training material should include practical and oral learning method with pictures and videos. When we talk about continuation, it was important to understand disposal, storage, resupply, and follow-up mechanism. Most respondents suggested that they will throw the used unit of DMPA-SC in the bin. Definitely that was a gap that we need to fill through the training. Women suggested that they can send their husband or family members to recollect the supplies from the health facilities, while community workers suggested they can provide resupply in their routine door-to-door visits. Most women understood the storage requirement, which is below 30 degrees Celsius, and can safely keep it away from the excess of children. Women also suggested to store the unit in cupboard or in a clay pot, particularly when temperature goes up to 45 degrees Celsius in summer. Many women do not own a phone, particularly in rural setting. Door-to-door reminder by a community worker is a conventional method that currently health system is practicing. Over to you, Gaia.
Hey, so this is really why it's important to have a formative research before you really do program implementation. It's interesting to know that, this relationship, even within the family unit, is very important to understand so that you would know how you would go about your program before just giving out self-injections in the community. And now let's go about more of for the government. So based on the findings in your study, what do you think are the key factors that the government must consider to be able to operationalize the pilot introduction of the DMPA-SC in Punjab? And this might be also helpful as well for others who are thinking of introducing DMPA-SC in their country or their area as well. Kanwal?
Yeah, thank you, Gaio. There are a number of key factors that government must ensure. First of all, of course, their support is very important. All administrative support to initiate this self-administration and attending all coordination meeting is critical. All FP service provider must be trained in providing training to clients for self-injection, which entails building their skills in coaching clients and helping them gain confidence. That is very important. Health facilities should have a range of FP commodities and enough supplies in order to provide an informed and unbiased FP choice to women in the community. Community outreach workforce should also be trained to provide refresher on self-injection to women and men, as well as to resupply next doses. Together, government and partners must expand access to accurate information about DMPA-SC self-injection to increase awareness, build interest, and spread knowledge about this innovative contraceptive option. Yes, Gaia.
Thank you, Kanwal. So is it correct? There should be accurate information, training provided, training, and of course, commodity, availability
Yeah.
of those commodities that must be provided within the community. All right. So thank you,
Yeah.
Kanwal. I'll get back to you in a while. So now from Pakistan, let us now learn from another Asian country, which is Nepal. So just to give the audience some context, the DMPA-SC was launched in 2 districts in Nepal in 2019. And since late 2022, the government has rolled out to 5 more districts and Far Western University, from which our panelist, Assistant Professor Govinda Dungana is affiliated with, is supporting the government initiative by selecting rural and remote villages of Accham and Kailali as its program district. So Far Western University is currently conducting a study in the rural and remote villages of Accham and Kailali districts, and which these are considered one of the areas with very limited resources in Nepal. And this study aims to assess again the feasibility and acceptability, this time of a community and home-based care team mediated DMPA-SC self-injection approach among women living with HIV in these rural and remote villages. So, Govinda, this is my question for you. So you just finished, I heard that you just finished the preparatory phase and are currently in the implementation phase of the study. So any interesting insights or lessons you would like to share when introducing DMPA-SC as an approach, especially within the context of rural and remote villages targeting a special population? Govinda?
Yes, thank you, Gayo. As while implementing this project, we have learned some of the success factors which are useful for to share with you. Yeah, I'm going to share with you. First one is the multi-sector collaboration. For example, national government, province government, local government, and organizations working in family planning, non-governmental organizations, that is international as well as non-governmental organizations, even resource-based organizations, and community-based organizations, and even the volunteer, female community health, FCSB, female community health volunteers, all are coming together, to scale up, to introduce and then scale up DMPA-SC in Nepal. So this means that multi-sectoral collaboration is a must for the successful introduction and scale up of the DMPA-SC in Nepal. This is the first thing we learned. Second thing we learned is that the government commitment is the most thing. Until and unless policymakers do not initiate, take concrete step towards this, the goal may not be achieved. In this regard, the Ministry of Health and Population Nepal, with special emphasis on family welfare division, has done very important things in the preparatory phase as well in the implementation phase. In the preparatory phase, the Ministry of Health and Population Family Welfare Division has coordinated with the international donors as well as other partner organizations to procure, to manage the DMPA-SC drugs. And again, the same partners have helped the ministry technical support to develop some guidelines, which are just which has been approved now. So these are the initial phase of government, preparatory phase of government initiative. After completion of the preparatory phase, government has rolled out the DMPA-SC project initially in 2 districts, and later it has added 5 more districts. So now at the moment, it is the program is smoothly running in all the 7 districts. So this is the second thing, is the government initiative. It has done training. First, it has given first senior manager. Second, it has given training to the health workers. In the last phase, it has given training to the cascade of training to the community level. So cascade of training for the promotion and the motivation of the health worker is the important which government has done. These are the second thing. And third important thing is the resource management. Resource management is the most important thing we learned from while working in this project, because mainly the resource means to manage drugs, one thing, to procure or to manage with the donor, to coordinate with the donor, and another is the resource for training and programmatic implementation. So government has done a lot of things for the resource management. Regarding the resource management, international donors and even the national organizations, NGOs have supported government to conduct training and the cascade of training. For example, Family Planning Association of Nepal has technical support and financial support for the training for the senior health workers. Similarly, Western University has received a grant from Clinton Health Access Initiative through Catalytic Opportunity Fund. This fund has been used for to scale up of the DMPA-SC in 2 districts, mainly Kailali and Accham districts. So in this way, regarding the resources, there are so many donors supporting the government. And third important thing we have it is that latestly government has updated the electronic record keeping system, where initially there was no separate column for the synapse in DMPA-SC. Now it has been updated. New column has been added for the DMPA-SC. These are the things that government has done. And lastly, I want to mention some of the limitations. That there are some gaps. That we have learned some gaps. For example, the government is giving drugs through some public channels. For example, private are not involved outlets. The distribution channel is only through public. Not private channels are not included. That I think this gap should be fulfilled in future. And second thing is that the government do not have some of the strategy to reach to underserved population. For example, rural area, how to reach to the women in rural area, and similarly how to reach with the special population like women living with HIV. So government have to think about this matter. Western University is conducting a pilot project in the Kailali and Accham district while targeting this population, women living in rural and remote villages, as well as the women living with HIV. So we are supporting the government in this way. Thank you.
All right. Okay. So like probably just to summarize, those insights are multi-sectoral collaboration, also mobilize the relevant government agency who will be coordinating with the international donors, having guidance on how to roll out DMPA-SC, okay, and then resource management, also to have proper electronic record keeping. But there are some gaps that exist, like distribution channel currently is only through the public, and also there's need for strategy to understand other population as well, like people living with HIV. So my next question is, Govinda, related to that, why is it important that self-care methods such as DMPA-SC be accessible also specifically to special population like women living with HIV?
Yes, thank you, Gayo. The women living with HIV receive their ARV drug from the hospitals. ART centers are located in the hospitals, but these women do not have. But the distribution channel to DMPA-SC to the local level, to the municipality level, local level. These women will HIV routinely visit the hospital, not to the health post or other local health facilities. So we thought that if we make the drugs available to the ART center or to the community and home-based care team, which are the HIV care provider, among which one of them is people living with HIV himself or herself, which are the community health worker, that CSBC team. So if we try to provide this drug from them, then the women living with HIV will have more access to this DMPA-SC. This is the first reason. Second reason is that Nepali women are contraceptive decisions are socially informed. This means that they will believe in their peers. For example, in community and home-based care team, there are two people, of which one of them is people living with HIV himself. So the CSBC team can easily convince her peer to take the DMPA. They can counsel very nicely. They can discuss openly. That's why CSBC mandated drug distribution would work more. We have the second reason for this. And third reason is that in our recent research, we found that a significant proportion of the women living with HIV are of reproductive age are widow. Although they are 30 years, 35 years, they are widow. So in Nepal context, widow women hesitate to it is culturally not agreeable, not in culture Nepal. So they want to take the drug in private. If self-injection is the best option for them who used to maintain their privacy. This is the third reason that we are trying to strengthen this approach through our project. Thank you.
Right. Thank you, Govinda. So really, it's really important to understand these special populations. So for those who are planning also to introduce the DMPA-SC, best to do research first and to understand the population that you are serving. Thank you, Govinda. All right. I'll get back to you in a while. So now Now, having heard from Pakistan and Nepal about their experience and also the studies that they have made, different differences and also in terms of culture, interestingly, okay, according to the Asia Pacific Alliance for Sexual and Reproductive Health and Rights, self-injectable contraceptives have largely been piloted in sub-Saharan Africa. And uptake in the Asia Pacific region has lagged behind. This is what is said in their publication. Innovative, self-administered methods are becoming more widespread, yet these remain uncommon in Asia Pacific. So to learn and also to understand from those countries who were the first in implementing self-injectable contraceptives, specifically the DMPA-SC, we have with us the regional director of the DMPA-SC project in West Africa, Celesta Compaore. But before I ask the question to Celesta, I'll first share an overview of what is happening in West Africa. So currently, the Bill and Melinda Gates Foundation is funding a project covering West Africa and implemented by Jhpiego called the Accelerating the Institutionalization of the DMPA-SC in 8 Ouagadougou Partnership Countries project. Oh, it's a bit long of a title for a project, but it's still a project, helpful one. This project is currently managed by Celesta as a regional director. And one of the objectives of the project is to coordinate and support the 8 countries in the implementation of their plans to scale up and institutionalize the minimum initial standards package for self-care in their budgeted national family planning strategic plans, in collaboration, of course, with the country government, the private sector, access collaborative partners, and other implementing partners. So this is really a very interesting project. So now our first question for Celesta. Self-injectable contraceptives, again, have been largely piloted in sub-Saharan Africa, but uptake in the Asia-Pacific region has lagged behind. What advice can you share to those who are still in the initial stages of implementing the use of DMPA-SC based on the challenges and lessons learned that you have in Africa? Celesta?
Merci beaucoup. Je vais intervenir en français pour permettre à nos collègues qui comprennent le français de se mettre sur la traduction. Merci Gaël pour donc cette question. Il faut dire que
follow us in both languages. Thank you. Thank you for this presentation. It is important to understand a number of elements here. We have, first of all, to have proof, evidence. Le gouvernement, the government studies population and sees what functions in some areas, not in others. So we need to see what works and why and where. So the introduction of DMPA-SC requires collecting evidence so that we can distribute this to community leaders. This is extremely important for the introduction phase. A second advice I can give you is guaranteeing good communication. Good communication requires good communication at the community level among the beneficiary population by showing the advantage of DMPA-SC, for instance, showing that it can be self-injected, given all the various options. The woman is autonomous and may decide when she wants to use contraception or not. What is very important is this autonomy of woman. She can do it when and she wants, if she wants. This is a method which, once the woman is trained, she doesn't need to talk to the health provider, and she's no longer dependent. And unlike the other methods where the women remain provider dependent. It is also important to mention that DMPA-SC contributes to expansion of the range of contraceptive products for women, but does not replace all other methods. This is important. A third advice I could give is improving the policy environment for DMPA-SC and self-injection. It is important to provide the country with a policy for the introduction and scaling up of DMPA-SC. This will provide a guiding document that will serve as a benchmark for the introduction of DMPA-SC, including the self-injection in the country. We will create a plan that will allow to measure at each stage what has worked, what are the options that need to be pursued, etc. So the health providers will intervene, but at the beginning, but it is not necessary once women are trained for them to be to go to the providers to get the DMPA-SC. Another advice, the capacity building of providers on DMPA-SC, including self-injections. The main actors who can promote the DMPA-SC, including self-injections, are the health providers. So they need to be trained to do so. And at the end of the training, the providers should be provided with all the necessary data collection materials, as well as all the other self-injection materials. Another important element, all these tools need to be translated into the local language, including the self-injection video. This is a matter of communication. The language of the country, of the area. This is absolutely essential because it will, and it should be shared with the clients during the initiation sessions. Having it in their own language will allow them to use them. So there must be a translation of the videos so that it can be shared by all. Most women have cell phones, so they can receive the videos there. And they need to be able to watch the video in their language to understand. And finally, the promotion of the peer-to-peer experience sharing. We are now at the level of experience sharing among DMPA-SC implementers and self-injectors in Africa. And we recommend that the Asia-Pacific region does the same because it does facilitate the distribution of lessons learned. So we need to make sure that DMPA-SC is available and at all levels, and commitments of the ODDs will be respected that way. So in a nutshell, this is the experience and advice that I could provide concerning the African experience.
Thank you very much, Celesta. And I'm happy that knowledge management, like peer-to-peer experience sharing, is also included in one of those, which is also very important, like what Celesta said. And my follow-up question for Celesta is, what do you think now for each country, what do you think must be done for FPRH self-care strategies to be fully implemented within a country? Celesta?
Ok, très bien. Comme je dis, pour moi, le premier...
As I was saying earlier, for me, the first element is it requires an appropriation of the FPRH self-care strategy by the country's administrative and political authorities. We need an action plan for the introduction and scaling up of the strategy. We need to have a response on this around a number of issues to make sure that the DMPA-SC is distributed, is known, is understood. So we need to promote also self-care within the community, make sure that there is an advocacy with community leaders on the DMPA-SC, and a pooling of efforts between the actors. So it is very important that there's an appropriation and ownership of the document. Second, that there are working groups that will work on this question and deal with their distribution and resolution. And we need to elaborate a strategy where we will be sharing our experiences. That's what I would have added on this.
Thank you, Celesta. So really ownership and also having strategy. So this has been emphasized many times, having strategy and guidelines also. And of course, learning from each other on how they do implement this self-care strategy, not only a strategy, but also how it's being implemented. So now I would just like to thank you, Celesta. I would just like to go back to Kanwal. Kanwal, what do you think are, so Celesta have shared some of the things, advice in terms of how can it be fully implemented in a country? For Kanwal, what do you think are needed for self-administered contraceptive methods be accepted and more used in Asia? Now, from the perspective, you know, from Asia.
Thank you, Gaio. I think quality FP counseling is something which determine an in-person self-injection training on a model is must. Women should be given instructional material with pictures, which is useful for women with limited education, and they can use that material at home while their next injection is due. So that material can help them to be self-sufficient. Also, government should ensure an uninterrupted supply of commodities, as we always face commodity supply is a major issue in many Asian countries, particularly in Pakistan. So that is very important, that there should be uninterrupted supply of followed by a quality counseling. Definitely, it includes the eligibility to determine the eligibility criteria of that woman, whether she can take that injection or not. If she is capable, if she is, if she qualifies that eligibility criteria, then she should be offered a self-injection training.
Thank you, Kanwal.
Yes.
Any additional thoughts, Govinda, on what do you think are needed for self-administered contraceptive methods be more accepted and used in Asia?
Yes, of course, I completely agree with the Kanwal Jazz counseling. High quality counseling is must regarding self-injection. But in context to Nepal, currently Nepal government has given policy, has approved for not self-injection, distribution of injection through administration of injection through health worker in context to Nepal. But government is doing research, planning to do research, formative research regarding self-injection, and hopefully government will approve for self-injection next year. So I think counseling and other factor are the main thing. But in context of Nepal, self-injection is not fully authorized till date, but government is planning to authorize it. Thank you.
Thank you. So quality counseling and also to do more research to make sure, to do more research to ensure that it would really be like from the Pakistan, right? How it will be more culturally appropriate to be more accepted and used in your particular country. So thank you for that, Kanwal and Govinda. For I'll go to Celesta. What can those working at the global level do to support those working at the national and subnational self-care initiatives in countries in Africa and Asia?
Merci beaucoup.
Well, thank you very much. Well, local, national, regional initiatives must be based on evidence, but also we need to put in place experience platforms as we have done in Africa, and also we need to continue to develop resources to implement this project and also extend the range of commodities. This is really of the essence. And also, the WHO and other international organizations should continue the documentation of all this at a local, regional level, and also try to support women in avoiding non-wanted pregnancies. So we need to
work in family planning in zones where there are still too many humanitarian issues in remote areas. And we need to help these women in terms of FP. We need to give them an access to FP services.
Thank you, Celesta, for those insights. And now, all right, we have a few more minutes. Thank you to everyone, but we have so many questions coming in. I'm not sure if we'll be able to answer all those questions because it's really a long list. You can see it on the screen, but it is a long list. So we will try as much as we can. So thank you first to all the panelists, Saumya, Kanwal, Govinda, and Celesta, for sharing your experiences. So now we will be opening the floor for questions. So apologies if not all questions would be answered right now. So the first question is for Kanwal. All right. From Peter, what foolproof M&E tools are available to track self-care uptake in different community settings, and how believable should such information be? Are there foolproof M&E tools available? Kanwal, would you know?
Thank you, Gayo. In fact, based on our formative research, we have designed our cohort study, and we have also designed an intervention model for implementation purpose. Currently, as per that intervention model, we are providing trainings to FP service providers, and they are getting training on quality FP counseling, how to train clients in self-injection, and we are also providing client instructional package, which includes all steps of self-injection with those pictures, and it also provides information in case of any side effect, what is the referral mechanism they have to follow. So it's a very comprehensive implementation research project. So we will definitely include many M&E tools in that research project and in that intervention model. And we will be able to share our learning when we'll start data collection. So at the moment, our protocol is approved, and hopefully we will start our data collection in February or March.
Thank you, Kanwal. Probably I'd also ask Saumya, because the common question is about monitoring checklist and indicators. So is there a place where they can take a look at, if there's a resource on that?
Oh,
Saumya?
that's a great question, Gayo. And in fact, I just put it in the chat that the Evidence and Learning Working Group held a series of consultations at the end of last year, and we've come up with a list of indicators on self-care that will cut across many different interventions. So it is for contraception, HIV, and one more area. So you can look at the range of indicators that are potentially possible and can be used at the country level. Of course, this is a list which will then have to be validated at the country level for these various interventions. But yes, so stay tuned and look for this resource to be finalized and put up on the SCTG website.
Okay, thank you, Saumya, and thank you to all of the other panelists who have been sharing also some resources that they know. So they have been sharing it in the chat box. So please do take a look at all these resources, are helpful audience as well. And another question is, all right, how to motivate potential self-injectors not to be discouraged despite possible challenges. Probably I'll ask Celesta, who has more experience in terms of that. So how to motivate potential self-injectors not to be discouraged despite possible challenges. Celesta?
Merci beaucoup. Pour les
Oh,
motifs,
thank you. Well, there are problems in terms of supply. Oh, there are some, I have some difficulties hearing Celestin. I've got an interference. We have to also introduce more self-empowerment. We must not forget the pandemic. That was another challenge. So there again, self-empowerment of women is of the essence. These are the elements that we can use to motivate the potential users. We must encourage women in using DMPA-SC, especially as self-injectables. Of course, they need to understand the self-injection mechanism. If they are afraid of using it, it's exactly the same thing as self-injecting insulin. So we should really encourage them to do this also with DMPA-SC. Sorry, the sound was a bit difficult for the interpreter. There was some interference.
All right. Thank you, Celesta. So it's really for to make people understand the mechanism of how it's being done. Like it's a good comparison. Like when people inject insulin also, it's almost the same, but people need to understand that. One more question is for Govinda. How can you sustain the demand in remote areas, considering the challenges in terms of supply chain, proximity to support? Govinda?
Yes, as I already mentioned that is the limitation and that the gap should be filled. I already mentioned that government is now distributing through public channels. We request government and as an advocate, we should to add these private outlets for distribution where there is through pharmacies and medical drug shop. If they are distributed through this channel, then we can easily reach to the remote area where small drug accredited drug shops are available even in the remote area, not so much big, but small shops, drug shops are available. From there, if we distribute those DMPA-SC, then the rural women can access to it. So government should make some policy. That is the policy level issue. That is some challenges, and that this gap should be fulfilled as much as possible. Thank you.
All right. So improvement really on the distribution channel, even small drug shops, so that it would be accessible for those in the remote area. All right. So unfortunately, we are out of time. We still have lots of questions. All right. In terms of, I know you're very interested on this one, on the DMPA-SC. Hopefully, let's see if I'll be able to send most of the questions again to the speakers, and we can send it to you as well back together with the recording of this webinar. All right. So thank you once again to our panelists for sharing their insights, experiences, and lessons learned on how to advance self-care in Asia. And thank you, our dear audience, for being with us up to now and actively interacting through questions and comments, and even sharing what you know to your fellow audience members. This is really very interesting and very happy to know. And we hope you learned something new. And before we end, we would like to share with you that our panelists, you can see on the screen, have developed a collection of resources on self-care on FP Insight. Okay, so for those who may not be familiar with FP Insight yet, it's a free platform that is helping family planning and reproductive health professionals find, share, and organize resources for their work. You can find many great articles curated by the panelists from today's webinar. You can see it on the link on the chat box, the link on the chat box. So all that your questions might be answered through the resources that our panelists have shared. They are the ones who made that collection on FP Insight. And we would also welcome all attendees to sign up for FP Insight today. It's quick and easy. You just need to go to www.fpinsight.org, and with an account, you can explore and save the 2,000 plus FP and RH resources on the platform, as well as also share your own resources to a community like what you're doing now, to over 900 FPRH professionals. And for any questions you might have on FP Insight, just send an email to info@fpinsight.org. And of course, to be updated on what's trending on FP and RH and on learning opportunities on knowledge management, subscribe to our website at www.knowledgesuccess.org. And before we close the webinar, we would love to hear from you on what would you like to learn more about knowledge management and other FPRH topics would you like us to discuss more in the future. Help us help you. So if you want more of these kinds of webinars, just click on the link that's being shared in the chat box today. It's just 2 questions. What do you want to have more in the future? What kind of learning opportunities on KM and family planning? So it's now in the chat box, just 2 questions. And again, while you answer those, thank you to everyone. Thank you to our panelists. Thank you to the audience for being with us today. And good day while you answer our survey. Let's listen to the music while you answer those surveys. And again, thank you everyone for joining us today.
Bye.
Bye, everyone. Please do answer the short survey.